Welcome aboard, folks. I'm Steven Malkowich, your captain on this adventure called Ship of Fools. I'm a fool. Lucky for you, I'm not sailing solo. Join me and a boatload of people, all just trying to make sense of this crazy world. It's a fabulous mess, and you're invited. I'd like to welcome you, Dr. Taylor.
Thanks for having me.
Dr. Taylor Burkinshaw. Mm-hmm. Okay. And I was going through, what do you call, it's a doctor of chiropractic. Mm-hmm. Mm-hmm. I was thinking a doctor of chiropracticacy, but that's improper. Mm-hmm. It's a doctor of chiropractic. Mm-hmm.
Yeah,
correct.
Yeah,
okay.
Correct. Yep.
Okay. And what we'll start off with is we've had many discussions over the last, 15 or so years.
Yeah, you've been a patient for a long time now.
A patient, and you've been more than blunt with me with my aging, and the things that I've been plagued with. Not plagued. I shouldn't say plagued with. Just the natural progression of aging. Mm-hmm. And but what I wanted to start off with was a little bit about your background and where you grew up with, where you came from, and we'll start with that and how you ended up where you are today.
Yeah.
Okay.
So I am a local boy. So I am from South Surrey. I went to high school here, just out secondary. Through high school, although my grandma would probably have said it happened a lot earlier because she had a story that when I was 10, that I said I wanted to be a chiropractor, although none of us can remember this at all. Both my parents were like, I don't know if that was actually true, but I definitely through high school, I did say that the chiropractic thing was kind of on the radar. I would say if I look back, I think what I wanted to do something in sort of the medical field. At that time, I don't think I quite understood the gravity of it and kind of what it all took. But so at the time, I kind of said physio, chiro, maybe doctor. I don't think dentist or optometry or anything was on the spectrum at that point. So I started to kind of just work towards that. I was an athlete through all elementary and high school. I played all sorts of sports. I golfed a ton, especially through high school. Soccer, I was probably my main sport. Played volleyball a lot in high school with the school team. So I did all that kind of stuff. I was just gravitated to it. And then went to university. My batch, I went there for food, nutrition, and health. Actually, I went to UBC, but I started at Kwantlen there, just kind of taking some general studies. Because at the time, again, I still wasn't quite certain on what route I wanted to go. And then when I switched over to UBC, that's when I sort of kind of was really leaning towards the chiropractic side of things. It was my chiropractor at the time. She was the one who was steering me that way, because I went in for an issue I was having with my neck. I would occasionally kink my neck, so I'd go in and see her. And I was telling her, I was thinking of going the physio route. And she said, well, you should keep in mind, that anything you do as a physio, you can basically do as a chiro. We all have similar schooling in the initial phase, and then you can kind of specialize out. So, and the one thing she said too, especially at the time when you couldn't get your doctor of physiotherapy like you can now, one of the things she sort of pointed out was you'll get a really good education on the chiropractic side of things. And now that I've been through it, definitely right, especially the Canadian school. The first couple of years is just mirroring basically med school. So your anatomy is second to none going through the Canadian chiropractic program.
How difficult is it to get in?
It was, I don't know about now, it was quite difficult then. So I actually applied early before I was done my undergrad, thinking okay, I probably won't get in without my bachelor's, and I ended up getting in. So I actually went that year early. But it's not easy, because at the time they would only let in, I think, 200 a year. Whereas the States, I'll probably get it wrong, but they have at least 2 entrance dates. Portland has I think they have a fall entrance and a spring entrance. So they kind of have 2 a year. And there's lots of schools in the States. It's not as hard to go down there for sure. And some of the programs are really good down there. Some of them are not as good.
Okay.
So.
See, my recollection of a chiropractor goes back a long time. And you were the first chiropractor that I went to out here. I grew up where had the stereotype of going to the chiropractor and getting hurt. Because that's what it used to. And when I hear that the term, I always remember being put on a table and going and then snap. Yeah. And and this is supposed to help me. I don't want to. So I'm saying that it was a big step to come see, and then okay, how's he going to hurt me? Yeah, and it was shocking that it wasn't the same thing. Like waiting for that. It wasn't a pleasant experience. Yeah, and I didn't understand how it helped. It helped me. Like and I'm talking like in the 70s and 80s. Yeah. So it's changed so dramatically.
It has.
And that's that. So when I've been seeing you for a long time, and we talk a lot, and so you're a local boy. You end up you get your undergraduate here. You go to Toronto. Yeah. And how long is that program in Toronto?
4 years.
It's 4 years.
Yeah.
And then once you're finished, you have to make a decision as to where you're going to go to practice, right?
Yeah, you got it. Yeah.
And
I immediately came back here.
Yeah,
everybody at school always joked that I basically graduated, hopped in my car, and drove home. I really like Toronto. I like Toronto and Ontario when I was there, but my whole family was back here. Yeah. Everybody was back here. So I came back, and I already had something set up with my chiropractor at the time. So I started at her clinic. And at the time I had actually thought it was going to be a really good fit, because she was more, I don't know if I'd call her necessarily the 80s or 90s chiro, where you'd go and you get hurt, you walk out and you'd be like, that did help. I don't know how though. And she was quite a bit softer, but still like, what I consider traditional chiropractic therapy is like cracking, manipulation, right? And adjusting. And that's kind of what she did. Whereas I was sort of kind of thinking I was going to be having my practice revolve a bit more around like rehab and soft tissue work, a lot of like different types of tissue work, like active release and Graston and all those kind of things. And so I thought it was going to be a good fit. However, I got into practice, and what started to happen was a lot of her patients started to want to see me. So then that became quite awkward because my practice started getting busier and hers started getting a lot slower. And so we parted ways. I ended up moving to the clinic that I have been at since, and I'm now partnering with my two partners. And we all practice, very similar. It was kind of our own little nuances, but all of us do a lot of rehab, a lot of soft tissue work,
So explain explain the terminologies that you just used.
So if we look at how like chiropractors treat in today's world, it's a large spectrum, because you do have chiros that, so you're going to walk in and you're just going to get adjust, like we used to call it the flying 5 or the flying 7, is you walk in, you get like both sides of your back adjusted, your mid back adjusted, your neck adjusted, maybe a few extremities, and then that was it. Maybe they grab that vibrating thumper that sat on their table next to it, and they'd kind of do that for the couple minutes to start, or they put you on some heat, and sort of that's your traditional manipulative therapy. Then sort of the world of soft tissue work started to get involved a little bit more. You had active release techniques, which is a very specific soft tissue technique, where it was trying to make treatment of your tissue a bit more specific than just generalized, like I'm going to treat the shoulder and then you're just going to do some muscle stripping or some deep tissue. Active release is more based upon range of motion. And so it's both assessing and treating within a range of motion and to your ends of range of motion.
Okay.
And really, when we look at sort of how everything progresses, the whole goal is someone comes into your practice in pain and not moving. So your goal is to get them there. Mm-hmm. And so all of these different, whether it's active release or massage therapy or rehab.
There's the G.
Grassin.
What is that?
Grassin's that when I use that tool. I mean, I've probably used it on you back in the day. It's like I call it abrasion therapy.
Okay.
It's when you rub on the tissue.
Okay.
And that's supposed to create like inflammation and bring in all the positive things to help heal your body.
Okay.
Heal the tissue.
Okay. So we've progressed and you've been out in the community here for quite a while, but one of the issues, and this is why I invited you onto the podcast here called Ship of Fools, which is reflective of the absurdity of life and things that are going on.
Yes. And
we're on this ship and we're oblivious to everything that's going on. And you in your position, okay, you have a lot of people that come in, okay?
Yeah.
And are, something's bothering them. They're not coming in because they love you. They're coming in because you're trying to fix a problem that they have.
Yeah.
And that it's some are serious, some are sport, the car accident, whatever it might be, a sports injury, whatever. But we have had multiple discussions about patients or people or the public, the general public, not willing to acknowledge there's certain things that you can do that can alleviate these issues.
That's the first time I've ever seen you try to be polite.
We're not allowed to swear for the first 5 minutes.
Okay, is that the rule?
That's the rule. I think we're not allowed to swear for the first 5 minutes.
Okay, we're there.
I know that's right. I'm being very polite.
Yes, people come into the practice to get things fixed, but they often, I wouldn't say often, because I have a fairly active patient clientele. Mm-hmm. But you definitely see it where they come in and they don't want to take responsibility for fixing themselves. That's where a lot of these therapies have come into play over the years, is people get injured and they want someone to fix it for them.
Yes.
And you can blame people themselves, or you can blame the medical model
or the pharmaceutical industry.
Yeah,
they created
take a pill.
Yeah, take a pill.
Right, which is so passive, right? But that's kind of how everybody got used to it. And even you see this like in America with their declining like health and exercise rates, and no one can exercise for you. It doesn't like that doesn't work. Like, and now they got Ozempic. I go, great, that's fantastic. Yeah. You can on the surface look okay.
Yeah.
That doesn't necessarily,
well, your body deteriorates.
Yeah, exactly. It's literally melting from the inside. Okay, so the outside looks good, great. So you're going to look great in your coffin.
You won't be able to lift a bottle of water. You'll look really good.
Yeah, oh, great. You're gonna be 80 years old and be in a wheelchair. You look fantastic though. An ounce of body fat on you.
So like let's continue. We'll continue along this path here because, and I know like we started and I have no problem showing this book here, Outlive. Yeah. Okay. By Dr. Peter Attia. And it's I read it quite a while ago.
Yeah.
And now everyone says, well, it's common sense. Yeah. It's common sense.
I wouldn't say what he says is common sense. It
gets deeper than common sense.
Much deeper. Like, I mean, I don't think we'll dive into the specifics. People should read this.
Yeah, that's right. And it's about longevity, and you're going to live longer. So if you're going to live longer, maybe you want to be in decent health when you're living longer.
He references healthspan and lifespan.
Yeah.
Right. Like lifespan's one thing, but if you're going to be old and decrepit through the last 20 years,
what's the point?
Almost what's the point?
Yeah. Yeah.
And I think that's sort of for what he kind of gears at is that the medical model isn't necessarily built upon healthy living. It's more built like the goal of pharmaceuticals is get you from point A to point B, and success is point B being a long time away.
Yeah. Yes.
But I think if we break that down a little farther, I think we can all kind of agree. I don't want to live till 95 if from 80 years old and on, I can't do anything.
Yeah. And you walk around with a respirator.
Right.
Yeah. What's the point? And that's, and the other thing too, I'm not saying embrace pharmaceuticals, but there is a role for pharmaceuticals.
Absolutely.
There is.
I have this argument in practice on a daily basis. People, I don't like to take pills. And I'm like, okay, that's great. But I mean, you just sprained your ankle, almost broke it, and it's twice the size as it should be. I think you can take an anti-inflammatory to help you out here. Mm-hmm. And then we can structure your rehab program based upon getting you back moving as quickly as possible, get you back to strength as possible. And then whatever activities that you do, then we'll get you back into those. And Advil or whatever anti-inflammatory or a naproxen that the doc prescribes or topical. Great. Those are great, but it's not going to fix everything. So we have to have, people have to take responsibility, and you have to move. You have to get yourself strong. You have to build mass for the inevitable point that our bodies do start to deteriorate on us a bit. I mean, no one likes to talk about it, but we can't be young forever. Yeah. And our tissue, the science doesn't lie that the tissue does age. Now, there's lots of things that we can do to try to help mitigate sort of that age-related decline in function, in tissue, and everything else. But at the end of the day, it is gonna happen. So we just have to do our best to try to kind of.
And you're unique in yourself, though, that because I come to you with some wackadoodle things, some things that T-Dog over here would maybe thinks I'm nuts. But the thing is, you never say that to me, to my face at least. But the thing is that you yourself have with your health, and I'm specifically related to your back.
Yep.
Okay. Yeah. Explain
So I mean, I've always had little things like different injuries, but kind of around mid-30s, I started to really just notice my back was bothering a little bit more, and I do my rehab and other things, but I was also kind of stupid too at the time, busy with kids, busy with life, busy with practice, busy with fixing everybody else. I wasn't really I was kind of pushing everything off to the side. So, but I was still exercising, cause I mean, I knew, okay, listen, you gotta keep moving. There's certain metrics that I really hold key to trying to live long, and that is try to eat a healthy diet, try to exercise. I try to lift weight 3 to 4 times a week. Try to hit your cardiovascular goals, which is, I mean, right now current standard is 150 minutes of zone 2 in a week. Yeah. And so I'm trying to meet all those, but I think at that time I was just fitting them in where I could and as quickly as I could. And so I was ignoring certain things. So I ended up sort of having this degenerative process occur in my back. And it's called a spondylolisthesis. So one of my vertebrae slowly just was shifting forward. And I mean, I don't have any prior imaging. I probably related a bit to the cycling I was doing there for a few years, like the road biking. And I think I was just putting myself in a position that was putting a lot of stress on my low back. And one of those segments became kind of unstable, and it was causing just a lot of pain in my back, some nerve symptoms down the legs. So I had an MRI done, kind of confirmed some of those things. And, so at that time I kind of had to take a step back and say, well, this isn't really getting better. And I kind of tried certain things, and it would calm down for a bit, and then it would kind of peak back up again. And so I finally was like, you know what, this isn't working. And I would describe it that I felt like my window for function was shrinking. And I really felt that. And I was trying my best to use all the different tools I had with, doing soft tissue work, going to see my physio and getting an IMS done, using a lot of the different rehab principles from different schools of rehab. And they were kind of working, but I just knew there was something structural underneath. So what I ended up doing is I went and started getting some PRP done to my low back, because one of the problems was that
explain what PRP is.
So PRP is when they take your blood, they spin it in a centrifuge, and they extract the protein plasma. Then that protein plasma is then injected back into the tissue, whatever that tissue might be. So in my case, they would ultrasound guide it right to where the nerves exit the spine in my low back, so in the lumbar spine. So that was being done to help to stabilize the region, because in essence, that's what the PRP is doing. It's creating a whole ton of inflammation. The best way to describe those injectable therapies is you have prolotherapy and PRP. They're very similar. Prolotherapy therapy is a dextrose solution with B12. And so they inject that in. That creates a big inflammatory response. And so what happens then is it causes the localized cells to lyse their contents, to expel their contents out. And that triggers a big healing response. So then the body sends everything it can at that tissue to help it heal. Well, the difference between that and PRP is PRP does the exact same thing, except now you've given all this stuff that is great for healing, and you've injected it there, and now it's sitting there, and now the tissue can use it. And so I found extreme success from this, because what I found is it coupled with all the other therapies I was doing, and I do believe that to be a big thing, coupling it with all the different rehab tools and exercise tools and activity and lifestyle modifications. I started to really feel like my low back stabilized, and it allowed me to really manage it.
Now, your other option, though.
Yeah, I mean,
let's talk about your other. Let's
right. So, if anybody else had seen that MRI, you would have been seeing an orthopedic surgeon.
Yeah,
and very likely would have had spinal fusion in that case.
That's surgery.
And they would want to put like a structure in the back of the vertebrae that helps pull the one vertebrae forward, open up the canals, and stabilize it. But you have extreme loss of function in these individuals. And those surgeries, like the results are all over the place. They're not good. And so I didn't like that option. Mm-hmm. I thought that was a crappy option. Mm-hmm. And I just had this feeling like, with my background, with all the tools that I had and the people around me, I just felt like I could probably attack it a different way. And I mean, at the end of the day, if I had failed, then I could go back and do that if I really needed to.
Yeah.
But at least then I would give it sort of a try to then come out of it with a lot more function. Now, I tell all my patients, it's not that I don't still have some back issues. Like sometimes my back, like it stiffens out. I'll wake up some mornings, it's a bit stiff. But I have a pretty regimen and protocol on what I do every day, what I do if I find my back is stiff. And I think I've just gotten smarter. And to be honest, my own issues with my body have probably been the biggest influence on helping patients. And that's probably where a lot of like what I do now, I would say, I mean, we get castrated if we ever say we have a specialty. But I would say that that's probably an area that I focus on a lot with my patients, is when you have an injury or a functional loss in an area, and it isn't just going to go away. Mm. What do you do? Do you just go that surgical route? Do you just pop pills? No, we sit down and we figure out a management strategy for that, and a complex one, right? That's going to involve rehab, exercise, treatment, activity, modifications, dietary modifications.
Do all these things, though, does our healthcare system encourage this or discourage it? Are you going to get into trouble?
No, I won't get into trouble. I don't think, I mean, to put an umbrella over the whole healthcare system is unfair because, yeah, there's certain people within that healthcare system that do discourage this stuff because they're ignorant to current processes and new research and how they differ. And you'd have a lot of people say, oh, PRP, whatever, that's not going to work. Well, I mean, if you look at some of the science that backs it and the reasoning behind doing it, even if you have no science background, it just kind of seems a bit logical. And if you have the right people in place, that seems like a good first step instead of going to quite a large step, and that is spinal surgery or any surgery for that matter.
Yes.
Even when you look at like sports injuries and someone ruptures their Achilles now. Well, now there's phenomenal research to not go ahead and get that surgery done, to put people in a splint that plantar flexes their foot down, approximates the two ruptured tendons or ends, puts them close together, and they will heal. And then you can even couple that with something like a PRP or some cold laser, things that are, again, then further stimulate and help promote the healing of that tissue. And then as it begins to heal, then you start to do select rehab exercises and strength protocols to teach the tendon how to reform and how to properly strengthen. And what you end up often seeing is better function after that. And so that kind of is the goal. And again, that relates back to us trying to live a long time, but also be healthy for a long time, is how are we also functional there? And how do we try to take these injuries we're inevitably going to get, right? And yeah, I mean, I blame my back a bit on certain things. And I did rupture a disc or herniate a disc when I was in my early 20s. So I'm sure that probably predisposed me to some instability and other things at that point. And that was before I was wise and didn't do my rehab like a stupid 20-year-old, right? And we're all there. Yeah. You know, and they're all in my office and we all laugh about it. And I'm like, I'm going to tell you things you're not going to listen. They're like, yeah, probably not. Right? Like, of course. Of course. And I don't blame them because I did dumb things when I was in my 20s too. We all do.
So where the question that where I'm going with this is that what we're talking about here is, it's not, we understand that things are going to happen. Like there's, you know, when you, like, I ask you this question all the time, is it just that I'm getting older or is that, and sometimes you go, you're just getting fucking older.
Yeah.
It's always, you know, you're going to have to accept, you know, you're going to have some pain in your hips. Okay. So this is what you know, okay. And you're just, it's not going to go away 100%, but it'll be manageable.
And that's something that I think the medical system in all fronts does a really poor job of, because you have certain people that don't know how to deliver that information in the correct way to not create chronic pain problems. And then you also have people who just won't say it. No, you're going to be fine. When maybe that's not true. And I would say in the early part of my career, I didn't like telling people that they weren't going to be okay. But I realize as time has gone on, you have to, I've had to learn to phrase it in ways to say to them, you're going to be okay, but this is not a condition that just gets to go away. And you're going to be like your 20-year-old self. It doesn't always happen that way.
And then put in the mental issue.
Oh yeah.
Okay.
That's a whole,
you know, like and we don't need somebody that's, you know, I'm going to say 5'8" 6 and weighs 240 pounds and comes in and complains, well, I've got chronic knee pain.
Sure.
Well, you know what? Put the fork down. Or I'm just, like, I know that's mean.
Yeah.
Well, I mean, maybe it is mean, but the thing is that message, and I look back at if we stop looking at food as just like food is a drug, just like any other, like liquor or sugar, like it's a drug, and that's the mental part of it. And having a conversation with somebody and saying, look, you know what, like like we live in a world where people who smoke cigarettes, okay, we know smoking causes cancer. We know that. Yet people still smoke, and they will continue to smoke till they die. Just, and so you look at, when that's absurd. It's absurd to be, and my father owned a bar, and he had type 1 diabetics drink themselves to death. And you go, like, how do we begin to address that? And I know that's the extreme. That is the extreme. But there are certain things that you can do. But is it, and I'm kind of coming around to the education part of things. When do you start to educate, like, people, like, and everybody didn't, like, I remember being resistant when they passed a law that you had to wear a seatbelt. I was one of those guys that got, like, more than one ticket. Get there, the man's not going to tell me to put a seatbelt on, and then I was like, what an idiot! It's not going to stop a car accident, but if I do get into a car accident, it's probably going to. It might save my life, and probably will. And so, where do you, and it's the same with the consumption of food, the consumption of alcohol, the consumption of drugs, and we're dealing with all of these things.
Coping mechanisms.
Exactly. The coping mechanisms. And so I'll ask you this question, maybe, and you've probably never been asked this question, like, part of your role doing what you do as a chiropractor, you're kind of a counselor too.
Oh yeah, that was my joke through COVID. I doubled as a counselor. I should have had a double billing goal on that. It was honestly wild. Like, I don't joke when I say that we were closed down for like 9 weeks, and there was people that came in the first day we were back. Like, I couldn't believe how many people rushed back into the clinic, and I swear to God, not a large percentage, but there was more people than I would have expected that came in just because I think they needed someone to frickin' talk to, other than their spouse or their kids or the person that they were stuck in their houses with. And it was a lot. Like, that was a time when I realized two things. I was underprepared in my career for helping people with their mental health. And it was also at a time for myself when I had to evaluate my own and say, maybe mine's not so good either. Like, because these people are making me go a little stir crazy here. And I think that probably happens for a lot of people through their whole lifetime is you mature and you kind of get to look back in retrospect and kind of see the things you did well and maybe the things you didn't do well. But yeah, like the mental health component to our overall health is huge, and you have to value it as much physical health and your mental health, because the mental health spills over so aggressively into the physical health in so many areas, and coping mechanisms is one of the biggest. Like, you have a stressful day, what do you lean on? Well, if we're going to pick something super healthy, we're going to get those people leaning on their exercise. But when you look at that can also be to the extreme. That's where you got all these Ironman athletes, and a lot of the time you have these crazy avid runners that are running 3 or 4 marathons a year. And I mean, those people are addicted to that exercise, and chances are they are using it as a coping mechanism for emotional problems within their everyday world.
So you think Goggins is doing that?
Well, I'm staying away from that. Guy'll hunt me down. But yeah, I do. I think that there's those extremes of using it. Now, if you give me a list of coping mechanisms, and we need them because we absolutely need them because the world sure ain't perfect and pretty.
Yeah.
Then I'm going to have you pick exercise.
Yeah.
Because that's the best one.
Yeah. But cake's real good too.
Yeah. Yeah. For getting plaque in your arteries. But to kind of rework back to where we were before and talking about how like you have people come in with, bilateral, both sides knee pain, arthritic issues, and they're 60 pounds overweight. It is a really difficult topic because how do you, when okay, this person has to get active, and like if we're going to use the knee pain, weight is a problem, and then muscle strength is a problem. So then how do you do that when the person's under pain? And that becomes more complex. And then chances are, if they are in a lot of pain, that chronic pain is going to start to have emotional consequences, which is going to have them lean into their coping mechanisms more, which are not exercise. Yeah. And so all of a sudden, now if their coping mechanism was cake, they're going to eat a lot of cake. And then that's going to cause them to gain more weight, which is going to have them have more knee pain, which is going to have them move less, which means they're going to get weaker, which means they're going to be in more pain. And it's this negative feedback loop that we see all the time in whatever area. And we're using knee pain, but it can be anywhere. Mm-hmm. And so this becomes, and everybody likes to give the medical system a really hard time, but at what point do you say, maybe that's not the medical system's problem?
Yeah.
Right? Like,
take some responsibility yourself.
Yeah, you got to do that. And you got to kind of,
but how do you,
easier said than done.
The thing is though, that part, taking the responsibility yourself, when you're young, you're dumb. Okay.
Totally.
You're really dumb.
Yeah.
You're really dumb. And it's like making like trying to find a doctor. Okay. Have a GP. Young people have a hard time finding a GP when they want one. Okay.
Yeah.
But in certain, I'm not going to name names in this discussion here, but they're close to myself and T-Dog here. And you go and you say, there's a new clinic opening up and they're accepting new patients and nobody does anything.
Right.
Because I don't need a doctor right now.
Sure.
Well, you know what? You're going to need one at one time. So you should maybe get it.
You should do it.
You should do it. Like that's just, you know what I mean? Like, and that's young and dumb. But the thing, what gives me hope with this though, is that, we thought for a long time, the tobacco industry had, like the ultimate lie that, this doesn't cause cancer. I mean, everything's fine with it. Yeah. And then it comes out, commonsensically speaking, if you smoked and thought it was good for you, like I'd have to question your sanity, really. But the thing is that, and I don't think a cigarette carton could get more disgusting to look at.
For sure.
And I think we've done a pretty decent job on the education end of the smoking thing. I think.
Yeah.
Like, but I don't, I have no empirical.
I don't know. Yeah. I mean, I don't have I haven't looked up the stats
on that. But the thing is though, that I always lean on that to say that education can work. So to bring it all back around here, what we're talking about is that, in the school system, in our educational system, if we teach this, I think
it'll start to sink in.
It may, you know, and it might take 30 or 40 years. But the thing is that it isn't the you know, the healthcare system isn't to blame for everything.
No.
You know, it isn't. But I do know this, that you know, you have to take responsibility for your own health. You do.
And the people around you's health. And I think that's what you're gearing at here.
Yeah.
Is that the people who already are in their latter years and they're having these degenerative issues and these health problems, we're just currently trying to do workarounds for them. But you're right. It is the younger group that we have to look at and say, well, there's still hope for those guys.
Yeah.
So we have to look at it. And in schools, we have to look at nutritional counseling and just general counseling of our own health to try and fix this problem. And I listen, I don't know how they do it, because that is a beast.
Yeah.
I don't know how you incentivize it. I honestly don't know.
Because the biggest thing coming out of this book here, that for me, that came out, was that these chronic diseases, all these chronic things, we treat them once you get them.
Correct.
You can do things not to get them.
Correct. That is exactly it.
Right?
Yeah. And that's for your internal health. That's for your physical health too. There's certain things you can do to help stop or slow down degenerative change in knees, right? There's certain things we can do to stop degenerative change in spines. Yeah. And we have to work on those early before they become a bigger problem. Like, you know, my back's if I had the foresight 10 years, even 5 years earlier, I probably would have prevented myself from having a lot of big issues, right? I didn't get on it early enough for myself to do that, but I'm pretty hell bent on trying to make sure other people that come into my clinic don't have to deal with that. And that it truly is because in those young individuals, when you see the movement patterns that cause the degenerative change, when you see people with unhealthy eating habits or coping mechanisms, that's when we have to get those people. And, you know, I think the physical or mental health side of a lot of this, I think would help a lot of this. And really, if we look at it closely, if you can try to help kids when they're younger develop those better coping mechanisms and how to deal with a lot of the emotions and everything else that they're going through and the stressful situations, then they're going to come out of it with a lot of the better coping mechanisms, or not necessarily even needing to rely so heavily on them.
Would you say that what's interesting in the times that we live in now is that information is available at your fingertips.
Yeah.
Yet it appears to be becoming more of a problem. And I'm talking about obesity. I'm talking about chronic diseases that are, and I'm not going to say, you know, cancer is not preventable. Yeah. You know, you cancer can get, but there are certain things that are going to happen to you that you can't control. Yeah. And we all know that. Everyone has a story of, well, you know, that grandpa of mine, he lived to be 100 and he smoked a package of cigarettes. Okay, well, woohoo, you know, that's the one. But the thing is that what I'm saying here is that we have all this information at our fingertips, yet we seem to be sailing along and not necessarily paying attention.
I don't know. Optimistically, I think maybe young people are getting a little better. Because it is there. I think you see the various podcasts out there and health influencers, and while a lot of them drive me crazy for how they interpret literature and information, at the end of the day, it's still trying to progress that movement forward to get people thinking more positively about their health.
So you're saying Donald Trump saying drink bleach to get rid of... Well,
yeah.
No, I'm joking. Joking, man. But
Well,
because that was, the prime example of that is Joe Rogan. Okay, we could talk about that. Saw some interesting debate about that. To say something and say, but I'm not a doctor. But I don't know. And that's also an issue in the podcasting world too. In with that information,
it is,
and what the source is, where you getting this information from.
Yeah, and he said that. I've heard him say this a few times, and I don't really listen to his podcast, but I've heard him say, I'm just doing a podcast. It's not up to me for people to evaluate that information, and he is right. Mm-hmm. It is absolutely. People have to learn how to vet information.
Yes.
But the problem is if you then if you introduce people as, oh, you're a doctor of so-and-so and you're a doctor of this, it is putting those people in a position of power. And even all these people who, with these big podcasts,
they move the mic up. Pull the mic up a little bit closer.
It is putting these positions of power, and it I think puts people who are just listening in a position where they have a sense of belief, like, oh, okay, what they're saying has to be true because they're a doctor or they're a psychologist or a psychiatrist or whatever. And that's dangerous because then people get really passive about their information. And if they're passive about their information, then that's when things start, when the algorithms start to take over.
Yes.
And you're going to start to see these AI generated things and people's reels that may not even necessarily be real. I mean, I can, if you Google things now, I don't even understand how you're supposed to understand where that source came from. Because how do you know if I'm pretty good about it. And even if you click, okay, where did this come from? Okay, you click on that. Well, okay, it's from this source. And then it's this rabbit hole where it's like, how are you ever going to have the time to figure out if that information was actually true and where it came from? And then the person who said it, like, where did they get that information from? And what study was it from? And what year was it from? And were there 6 studies after that study that actually refuted it? Right? One of the clinicians at school, I remember he's like, you could read 25 papers a day and you wouldn't be able to keep up with the new literature coming out. You can't keep up with it. And so that's part of the issue is how do we get the correct information to people? I don't know. I don't
like in the province of Alberta right now, they have 1,000 measles cases. Okay.
Oh, I didn't know that.
Yeah, I don't think I'm making that up. I'm pretty sure there's over 1,000 measles cases. Okay, what's going on?
Yeah,
what
I think you can say that with a lot of things. What is going on right now? Why do we keep seeing all these different, various conditions come up? Some things that we thought were long gone, some things that were really rare but now clinically aren't so rare. And I don't know. I think if you look at it objectively, I think it just comes to down to the same thing as everything else that we've been talking about. It's just cumulative, problems in our exercise, our food, everything. And that's why a lot of these chronic conditions are coming up, whether autoimmune, whether or not they're infectious diseases.
And like even if you look in the way you were explaining about going down the rabbit hole, I always try to live by the standard of trust but verify, and that's even difficult to do.
Well, yeah, you're in the news, like that's right. Business, like that is your business,
exactly. Trust but verify. Well, T-Dog and I had this conversation just the other day about what we were vaccinated for when we were young.
Yeah.
I don't know.
I don't remember.
I don't.
Totally.
I remember, I do distinctly remember a cube of sugar with something pink on it. I don't know what that, you're not old enough for that. But we just came to school one day and everybody lined up and got a cube of sugar. And I don't know if that was for polio or I don't know what the hell it was for. And nobody, and I don't even think our fucking parents, like, it was just, okay, everybody, okay. But, or if we're getting a jab, I don't know what it was for. I know I don't. I don't know now. Like, what are they? You have 2 young children. Okay. So
what are the vaccines?
What are the vaccines?
Oh, God, I don't even know. I just looked this up when their next one was going to be. I think that was
what's
for
it for?
A couple of years. They get the mumps, the MMR,
Measles.
They get chickenpox, they get polio. Well, yeah, I'd have to look it up.
Yeah. So, but the thing is,
it's a lot.
It's a lot. And the thing is that when if somebody questions that, like if you're a parent and you question, you know what, I don't know. And listen, I'm not, I don't consider myself to be a conspiracy theorist. I don't. But those COVID vaccines came out pretty quick. And I'm going to put my conspiracy theory hat on now.
Here it comes. Well, I mean, have we sworn yet? No. I don't think so. We've been good.
But that was one of the first things I said. I think I said to you, I thought, I'm telling you, that's what did it. I'm telling you, because I remember I was in the gym in San Francisco and it wasn't feeling good, and that wasn't gym sore. There was something going on, and that just, it was that happenstance that I got that last shot, and going, I don't know. And the interesting thing is that, my rheumatologist will probably never ever watch this. I won't mention her name, but what was interesting is that, even with my GP, but the rheumatologist, it started off with, I was dead when I saw the rheumatologist. I was saying it was vaccine. I'm guaranteed. And she, no, denial. Now it's more, okay, well, I'm not even going to say a maybe.
Yeah.
We don't know. We're seeing some cases, that kind of thing. So that also, see, me just saying that and being a parent, if I had being a parent of young children and hearing that going, okay, Jesus, like we didn't, I didn't know when I was in grade, whatever it was, grade 4 or grade 5, and we got the pink sugar cube. I don't know how many kids got sick after that. I really don't. Were violently vomiting when they went home. I don't know. I just went, okay, well, you know what? Sugar tastes good. Who doesn't like sugar? And it was supposed to have some sort of something on it. I don't know. We should look at, if we were appropriately set up and T-Dog was on the internet, she'd be able to pick that up and look that up right there and see what were they putting on the sugar cubes in 1974. But the thing is that there is a lot of information out there, and a lot of inaccurate,
Correct.
And how do you vet it? How do you vet it? And
this is a really good question. And for liability reasons, I don't talk about vaccine stuff at all. Just because it's too polarizing. Now it's also not my specialty, but I will say this for people that, just, control what's in your control. And that's where we kind of re-loop back to your health, your general health. And that's to say, exercise, eat properly, control your mental health, do all those metrics. And if you do those things, hopefully everything else works out. Right. And yeah, I mean, the COVID vaccine it was, I think, one of the first times probably in our history that I am aware that there was sort of this here, come and take this, or we were take it, but there was not this mandatory kind of component to it, or at least it was the first time where it became obvious that it wasn't mandatory. And I think that's where you see it now, is you had some people really against it, some people that were really for it, and you had that polarizing nature to it. And that's where a lot of the disagreements and everything have.
Now, you may not be able to answer this question because of liability issues, but in your practice, if you can't comment on it, but have you had patients that have come in that have issues that you have to deal with that you could assume could be COVID, that's shot related, or it's
pretty hard. And no, like I can't say I have never had a case where someone came in and I said that was for sure because they got the COVID shot. I will say this, I've definitely had a few things that I had never seen in 10 years of practice, and now I've seen in a matter of a couple of years. And a lot of them seem to revolve around COVID, getting COVID or getting a vaccine. But I don't know what the linkage is there. You and I talked about it a lot with some of your health stuff, that we did see this weird, and this is what the rheumatologist was likely pointing to, is we did see a really weird kind of uptick of polymyalgia rheumatica cases, right? Do we know why? No, we don't. Well, is there some theories behind why? Yeah, there is. So that's sort of on the probably to be continued, in terms of science and data, and then how much of that data really gets out. I don't know. It's really hard to tell in any condition what causes it, because, like look at cancer. We don't know.
Yeah.
Like genetics, health, food. Good grief. Yeah. The amount of things that can cause genetic mutation in the world, we can't, you're never going to be able to just hammer down and say, that's exactly why you got cancer. Right. And so there's always going to be this unknown to that. And, that's maybe where we got to rely on some of those coping mechanisms, because we're just never going to know.
Now, in your humble opinion, at what age do your patients, you run the whole gambit of ages, okay? But when when does are young people more prone when they're involved in athletics to come and see you over an issue than those that aren't? Meaning that, the
younger people. When I see young people, it's usually because of sport related injury, or at least tied into that. I don't really see, maybe the odd occasional scoliosis related complaint or headaches or that kind of thing. Or maybe a little bit of back pain in younger individuals, but for the most part, it's mostly sport related.
And then as people age,
yes, and then it crosses over to non-activity. You still see lots of activity related issues, especially and demographics and where I'm located would. Is said and is it because of their being sedentary? As people get older, how I like to classify it is I see people for more degenerative related problems, chronic lower back pain related to arthritic changes, disc problems, weaknesses in the core because of that. Labral tears in hips, tendinopathies. I see people for a lot of that sort of thing as the years start to go on. And then it's our model begins to shift a bit to how do we help these people? Because if you can't fix them, our job, this is something that is always a bit of a pet peeve of mine, is everybody tries to, in my field, whether you're a chiro or physio, whoever you are, you're trying to diagnose it, and then you do diagnose. So let's say you diagnose someone with an arthritic hip that is moderate arthritis. So they can't get it replaced yet. And it'll probably be a few years. Okay. So people will throw a little bit of stuff at those individuals and say, oh, do these exercises, try and get the hip strong. But they're kind of left in no man's land, right? Or you got your chronic low back guy who maybe has some facet degeneration. And they're just said, okay, here's McGill's big three, which is Stuart McGill, one of the best researchers in the world on low back issues. So he has 3 exercises that has been shown to be very good for dealing with low back related problems and building strength around the spinal column. Okay, so a lot of people are given those, but that's just like this like broad like, oh, just do these and throwing shit on a wall and hope it sticks. Whereas if that was an athlete who had to compete in, a professional athlete who had to compete in a couple months or in a couple weeks, well, then all the practitioners are falling over themselves to try and help this person. And so that's a big pet peeve of mine because, what about the person just trying to get up in the morning and not be in pain? Well, how are we helping those guys?
Yeah.
Right.
Yeah.
And how are we being empathetic to their situation, like their lifestyle constraints, their work constraints, like what's going on in their family life, what's their emotional health like? And that's where a lot of the help falls off is you don't help these people that don't have either a clear Achilles tendinopathy that you can do shockwave and BFR and laser and rehab to and get them better. And then they can walk out your door and you can be like, it worked, right? That's a great picture, but that doesn't always happen. The hardest people to work with, which is why it's done so poorly, are the conditions that are not 100% amendable to care. Those are the ones that are not looked after well. And I think that's part of like my low back would fall directly in that category of something that by a lot of medical professionals, it's not looked after well. Because I think everybody kind of puts their hands up and they get frustrated. Like, oh shit, I don't know what to do with that.
Yeah. And what ends up happening too, if you're not, if you don't have, it's real easy to accept pain as being a normal part of your day. You know what I mean? And then you just go, well, that's the normal. That's normal. And what's always interesting for me is that when I have an injury, when I have pain, you don't realize how bad that pain was until it goes away, and you go, Jesus, I was doing all this stuff here. And in your opinion, what's a potential solution to does that fall on the healthcare system?
It can't. They don't have time for that.
It's impossible to.
That's impossible.
It's impossible to. So then the next step is education.
Absolutely. Now, there can be programs. It's hard to say what would be the best model. I mean, it's going to fall on private practice, but I mean, private practice, there's financial constraints.
Yeah.
Right. So not everybody is necessarily going to have access to that. They may not have extended health benefits. They may not have extra resources to be able to pay for it. So then can there be government programs that help them? I mean, there's lots of chronic, government run chronic pain clinics, but they're hard to get into. They're decently structured, that try and help people work with it. But I mean, even when you look at the chronic, the pain science world of what the counselors and all of the pain science people are doing, it's the government run is about dealing with the pain and just and not focusing on it. Whereas when you look at a lot of the pain science stuff, it's more about like what's causing the pain beyond, like, are there factors that are modulating your pain higher? What's going on in your family life?
Mm-hmm.
Are you sleeping properly?
Mm-hmm.
What
are you eating?
What are you eating? Or is there high inflammatory issues? And so a lot of the chronic pain programs don't necessarily deal with that.
Mm-hmm.
And so, yeah, like, what do we do about that? I mean, that's where multidisciplinary clinics were supposed to help. That's when you had physios and chiros and naturopaths and nutritionists and kinesiologists all working together. But when you step into most of those multidisciplinary clinics, it is just a bunch of individuals working within one space, mm-hmm. right? It's not collaborative care. Now, don't get me wrong. I understand why that occurs. Business is business. Mm-hmm. And when you're running that business, collaborative care is very expensive. And so the average individual either can only get some of it or none of it at all. Mm-hmm. And so then they're trying to rely on the individual. And that's the hard part.
That's the hard part.
Is how do you structure that? Now there's different, there are private solutions to this problem, but again, money is everything for that. Yeah. And so that doesn't help your average individual, which again, that's the problem. If money wasn't the object, if resources were, or not the object, if money wasn't the problem, if we didn't have to worry about it, if resources wasn't a problem, we had all these clinics that were everywhere that everybody had open access to. Well, you and I wouldn't have to talk about this, mm-hmm. but we do because the average individual cannot access that stuff. Mm-hmm. And so what ends up happening is it falls on the medical system. So it falls on your family doctors. They are not positioned to be able to do that.
They're not quick. No.
You have, people like myself in the healthcare system that are trying to provide, resources. And when I deal with this in practice, I'm giving people all sorts of I treat them. So I'm helping their tissues. I'm giving them exercises. I'm trying to create, positive environment around activity. You want people to have a positive association with exercise, mm-hmm. not a negative association. And so then I work with people a lot on that and trying to, what can you do? That's something I say with people all the time. What can you do? Mm-hmm. Right? Okay. Can you get up and walk around the room? Great. Do that.
Yeah.
One of my patients, he just, got in a bike accident that I'm going to have to be dealing with. So I was messaging him mm-hmm. this morning and just kind of checking on how he's doing because it just happened on Friday. And he was kind of giving me the lowdown on what's going on. I just said, okay, I know this is going to be hard and you're not really going to want to do it, but I want you every single hour getting up and walking around for at least a minute or two and I was kind of giving some put some heat on here, but the goal was I want you active as much as your whole body hurts because you just got hit by a car. Mm-hmm. Let's get you up and moving mm-hmm. because right now it hurts way more, but a month from now you'll hurt way less because we worked right now. Mm-hmm. And so that's all to scale. And that's part of what we have to try and deal with people in all these different types of conditions mm-hmm. is say, okay, what can you do? Well, let's get you doing that first, mm-hmm. right? And let's get you not hating it. And then let's work you back, let's work you from that point and work towards the goal, whatever that goal is. And, sometimes in complex cases, one of the things I like to ask patients is, what are your goals? Right? And find out what that is. Do you want to run? Do you want to lift weight? Do you want to water ski? What is it? Mm-hmm. And then we put those kind of at the top and say, okay, we got to get there. So then we reverse engineer it. And mm-hmm. how do you get there? Right. And it's different for everybody.
One of the things, and back to the book here, too, and that rung true to me was messaging. We're going to live longer. We are going to live longer.
Yeah.
That doesn't necessarily mean that we're going to live a better life longer. Mm-hmm. And what ends up happening is that it's not sustainable. Our healthcare system, and it's just, it doesn't matter. You could say Canada, the United States, doesn't, anywhere, the world. For our healthcare system is not, it is not set up for people to be living to be 85 or 90 years old, and it could totally incapacitated and not being able to do anything.
Yeah, for sure.
Seriously, like we're not, and that's a paradigm shift. Yeah. I don't know. That's always been the case, but it's a paradigm shift in the fact that we're understanding that we're actually sitting here talking about it, because honestly, it doesn't come up in a conversation. And as you know, everyone has aging parents, and I've witnessed that and gone and seen, one parent who, I can just use my father, for example, cancer got him, but till his dying day, he was busy. He was doing stuff. He was golfing, he's curling, he's doing everything. And I have a mother who's still alive who wasn't like that. And that creates a whole, that's an issue. And that issue, that paradigm shift, I think is just going to become more and more evident as we age and we see, at the end of the day, are we going to be, do you want to live there as an 85-year-old with a tube?
For sure. And so then how do we define long that long? That's what that's right. What Peter Attia talks about is how do you define that? Yeah. Then because that's that lifespan idea, but man, that's a shitty health span.
That is. That's right. That's right.
So how do we change that? And again, it's the passive thing, right? Everybody wants the passive model to that. I just want to be given it. Yeah. Right. I want the government to pay for it. I don't want to go do it myself.
Or I don't even want. I
don't want to.
I don't want to.
And some people don't. And you know what? At the end of the day, that is what it is. Yeah. Then those people are going to shift into, in their latter years, the medical, medicine 1.0, as Peter Attia likes to call it, they're just going to kind of shift into that model, and that's fine. That we can't, those aren't the people we need to be. I don't want to say wasting our time, because I don't think that's empathetic, because I think everybody needs to understand the person who's obese, there's a reason for that. And it wasn't just because they decided they wanted to eat. There's a lot of other stuff going on, but it's not necessarily up to the medical system to fix that, right? It's not always up to government to fund everything. Otherwise, no one wants to pay more tax, but
that's right.
For sure. Yeah, really, right. No one wants to pay more tax, but everyone wants everything done. But you can't do that. It doesn't work that way. The funds aren't there to do it. So then I personally think it's not about, we probably do need more funds in healthcare, but I think it's about reworking what healthcare is responsible for. And then maybe, I don't know, incentivize everything else, right? Well, tax write-offs for whatever.
That's one of the things, like with an insurance policy. The first thing do you smoke?
Right.
Do you drink?
Right.
Okay. So we can incentivize these types of things. Yeah. We can.
Absolutely.
Like we can't. We're capable of doing that. The insurance industry sure as hell does it. The automobile, when you're a 16 or 17-year-old male and you get your driver's license, your insurance is through the roof, because the chances are you're an idiot, and there's a high likelihood that you're going to get into an accident, so your premium goes up. That works. It works. It does work. Health look at that model and say, okay,
how do we provide something?
That's right. How do I incentivize you
Mm-hmm.
to and maybe and I know like your kids are young, so the easiest thing to do is when you're busy, you like get shit food, whatever, just stick them in and put an iPad in front of them and feed them shit food.
Sure, that's the easy way to go, but
it is. But you got to think about it.
Mm-hmm.
You actually have to think about it, and you should be incentivized to make the right
decision.
I don't want to call it the best
decision.
The best decision.
Yeah, no, for sure.
The best decision.
You're right, because saying the right decision is
everything
up for interpretation.
That's right. Everything's nuanced.
Yes,
it really is.
For sure.
It really is. And like for one person, just going for a 20-minute walk once a day, that's fantastic.
Mm-hmm. This is a really good point, actually. It's the hard thing with a lot of the science, because it comes on and says, okay, so like let's look at the cardiovascular metrics that we're supposed to meet. Okay, so 150 minutes of zone 2 a week. Well, to someone who doesn't move, if you slap a watch on them and you get them to go for their walks, that will be enough initially.
Yeah.
Because especially if there's a few hills thrown into that walk, they'll be in zone 2 most of it. Great. That's perfect. But that person who moves around all day, like I like to use the construction worker, right? That model of, well, I'm moving all day. Well, that's great. But part of the problem with that is, yes, you move all day, but you're in zone 1 the whole day. Your body's become accustomed to that movement and those lifts and of whatever your tasks are at your job. And so it no longer becomes exercise as we see it for cardiovascular health.
Mm-hmm.
Walking every day for 20 minutes, at that point, we might almost like, yes, it's good for your health, but it's probably better for your mental health at that point, because it's not going to meet our cardiovascular guidelines, right? And those guidelines are there for a reason, because we know to keep your heart and your cardiovascular system healthy, you need to be doing it. And 150 minutes is the minimum.
Mm-hmm. And when you think about it, though, in a span of a 7-day, that's not a lot.
No, it shouldn't be. And like,
it's not.
And the other thing is, so it seems like a lot when you say, okay, so 150 minutes of exercise or of cardiovascular exercise, then you're supposed to have, I think it's 2 45-minute or 30-minute strength sessions. Okay, so great. So now we're at, let's just call it 3 hours a week. Well, no, I guess that's terrible math. Let's call it 4 hours a week. That seems like a lot to someone who doesn't move.
Mm-hmm.
And so that's part of the problem with some of the new research coming out and how it is then presented, not by the people doing the research, not by the people like writing the books, but by the algorithms throwing it at people. Mm-hmm. Is it seems daunting. So then it's like, oh, well, if that's it, then why even bother?
Mm-hmm.
So when those people are in my clinic, the first thing I say to them is, again, what can you do? Can you give me a 15-minute walk? When I'm dealing with disc herniations, that's a lot of the Michael Shacklock is one of the biggest researchers in nerve health and how nerves move and slide and glide within your body, how they exit the spine and the compressional forces that go on them. He has a whole course on it, which I've taken a lot of his stuff. And one of the studies he did was they looked at people with disc herniations, and they put people in 2 groups, and they had people get in this, what he called an opener position, to help to bring blood flow to the compressed nerve root. And then they had them move. You had to walk at least 45 minutes a day. And they had a control group that was just given drugs. I believe the experimental group also was given the same drugs. Well, the initial time they did that study, they had to stop the study because it became so unethical. Because the experimental group got better so much faster. And so that in itself is just like a snippet of showing you like or the old model of like someone had a put them in traction in the hospital. Like, oh my God, that would have been the worst thing to do to someone now that we know that. But the easiest thing was just get that person moving. Well, the same thing goes for someone who isn't meeting their cardiovascular or their health. Just get them doing something and get them liking it. And then you can work. It's the same thing in rehab. If people aren't doing my rehab, then I try and find something they like. Yeah. I find an exercise they like and I get them doing that one. Yeah. Even I don't even care if it isn't going to necessarily help the issue I'm doing, as long as they get in the habit. You know, like in my early part of career, when I give people exercises, I'd say I just try and do them like 3 times a week, 4 times a week. And now I just tell them do it every fucking day. Because not because I think it needs, I necessarily think it has to get done every day, but because if I ask for it every day and they do it every day, they're more likely to do it because it's a habit. Yeah. Right. It's way easier to get your brain kind of around. Okay. I just got to do this every single day.
It's like brushing your teeth.
Yep. 100%.
Like brushing your teeth.
So yeah. Anyway.
And okay. Well, listen, we've been going on here for a long time.
Yeah. Give tangent after tangent.
Yeah, that's right. And give your clinic, Grandview.
Yeah.
Give it a plug.
Yeah. Grandview Health Group. We're just located in South Surrey here.
South Surrey.
I was giving multidisciplinary clinics a hard time, but we are a multidisciplinary clinic. Yeah.
And Dr. Taylor Burkinshaw. Yeah. You can look him up on Google. We've had many interesting discussions when I've been in there for treatment over the last number of years. And finally, when I told you that I was doing this podcast,
thanks for having me on.
You know, and it's, you know, it's kind of a misnomer saying that it's a ship of fools. But the fact is that, you know, you read a book like this or and you go, okay, well, like, are we all the absurdity of, you know,
yeah, well, when you shine light into the dark, it's amazing what you find.
It is. But once again, Taylor, thank you so much for coming on.
Thanks so much.
Really appreciate it. Okay.
Thanks so much.
Thank you. You may be asking yourself, what's any of this got to do with me? Absolutely nothing. Until next time.